Miss Wells is a 28-year-old African-American woman with a history of asthma that was diagnosed at the age of 2.5 years. She's had no prior intubations but 5 hospitalizations for her asthma, with the last being at the age of 16. She presents today with complaints of shortness of breath and wheezing following a near asthma attack that she had 2 days ago. Her asthma symptoms were triggered when exposed to cats at her cousin's house. At the time of the asthma attack, she rated her wheezes as a 6 out of 10 and her shortness of breath as an 8 out of 10, which lasted for 5 minutes. She states her symptoms are worsened when lying flat and with movement accompanied by a non-productive cough. At that time, she used her albuterol inhaler and her symptoms decreased, although they did not completely resolve. Since that incident, which was 2 days ago, she's had 10 episodes of wheezing, as well as shortness of breath approximately every 4 hours. She also states she awakens with nighttime shortness of breath twice per night. Her last episode of shortness of breath was this morning before coming to the clinic, but states her breathing is currently normal. She complains that her current symptoms are beginning to interfere with her daily activities, and she's concerned that her albuterol inhaler seems to be less effective. She is not aware of any environmental exposures or irritants at her job or home that could be causing these symptoms. She denies current use of tobacco, alcohol, and illicit drugs. However, she smoked marijuana 5 to 6 years, but stopped 7 years ago. Miss Wells is alert and oriented and sitting upright on the exam table. She maintains eye contact throughout the interview and exam. Chest expansion is symmetrical with respirations, normal fremitus, symmetric bilaterally. Chest resonant to percussion, no dullness. Bilateral muffled words with notable expiratory wheezes in posterior lower lobes. No crackles. Her in-office spirometry was noted with a FVC at 3.91 liters. Her FEV1 to FVC ratio was 80.56%, and her SpO2 was 97%. Based on this information, I would initially diagnose Miss Wells with moderate to severe asthma. She should be educated on the incentive spirometer and educated to monitor peak flow values daily. Since she does not have a current pulmonologist or allergist, I would recommend she sees both, as a pulmonologist will be able to dive deeper into her lung function and determine any conditions that may be causing or contributing to her asthma, and an allergist will help her identify any asthma triggers so that she can avoid any allergens or irritants. I would prescribe Miss Wells a medium-dose inhaled corticosteroid and a long-acting beta agonist, such as formoterol, as maintenance and reliever therapy. I would like Miss Wells to follow up in 1 month for an reevaluation of therapy.